This is the We Can Do Better podcast. And I am super excited because our guest this week is literally my very favorite doctor in the entire world. And I know she'll say, oh no, I gotta like other people, but that's not true. She is my favorite. My eldest daughter was almost named Michele Thomas because on a very scary Saturday morning, she delivered the most amazing little girl in the whole wide world and made sure my wife came home safe. And so she has done that with our second child, AJ, and I'm sure countless others. But as we talk about, and as we start to talk about these kind of things and we think about those moments, childbirth can be very scary, and who you have as your doctor makes a huge difference, especially for Black women. And so before I introduce you to Michele Thomas, let me tell you how I found her. So Crystal and I decided that we wanted a Black woman OB, particularly Crystal, because she knew all of the issues and other things that are associated with getting that kind of care. So I asked all the Black women in the medical field, all the Black men I knew in the medical field, everybody I know, I was like, hey, who are the best Black women doctors you got? They gave us a list that we narrowed down to about 50 people. And then I handed that list to Crystal, and Crystal looked at people's CVs and their resumes and looked back. And people were like, you did all that to find a doctor? And I was like, yes, absolutely. And then from there, we whittled that list down to about 20 people. And then we had first round interviews with those 20 doctors. And then we did second round interviews with, I think, the top 4 or 5. And we selected Dr. Thomas. And people always are like, y'all are some weird people. But in that moment, I said to myself, this is the most, this could be the biggest day of our lives, and it certainly in our case was the scariest moment. And I knew without a shadow of a doubt that when Dr. Thomas came in, and I swear to you, I will spare you all the gory details and everything, but it was a scary moment. And when Dr. Thomas came in, I swear to you, I heard the Shaft music, because she came in control, and all the other doctors were like, okay, yep. And she wheeled Crystal right out. And the attending doctor, first thing she came in to said to me, right after mom and baby are okay, because I was like going a little crazy. I was like, and she's like, yeah, mom and baby are okay. And then she said, if it had been another doctor, I don't know if they would have been. And so I want to introduce you to, again, my very favorite doctor, Dr. Michele Thomas. If you want to introduce yourself.
Thank you, Adam. That was just super generous, and your story, it just elevates, and it's been a pleasure to take care of you guys personally. I didn't know all of that background though. I do remember you and Crystal came. I remember you guys came in with a notebook.
Yeah.
And I was like, they're serious. But my name is Michele Thomas, as Adam said. I am born and raised from city of Detroit. I attended Cass Tech High School. I went to undergrad at University of Michigan, then jumped over to medical school in Ohio at University of Toledo, and jumped back to medical residency in OBGYN at Wayne State. I've been practicing for a long period of time. I'm currently in private practice. Southfield OBGYN is our practice, myself and Dr. Patrice Harrell. And Adam tells that story with relish. It almost makes my heart flutter. I didn't know that he was so observant about the situation. But I remember you guys very distinctly. I remember everything about that day very, very distinctly. It's an honor to be on the show.
I remember it distinctly because it was one of those things where literally every possible thing went right after the scariest thing went wrong. And, Crystal having a placenta abruption. And, everyone always says your doctor's never going to be there, right? Like, I was like, and the doctor is actually literally in the hospital at like 5:30, and a shift change. I don't think you knew this, but I lost my keys. I literally lost my keys coming in. They were under my rear tire, frozen under a sheet of ice.
Wow. Oh, wow.
But, it just, and that's why I tell that story, because it's so important that this is literally the biggest decision that a lot of people make. And often they're just referred by, their insurance company. It's like, do you take my insurance? And that's such a different way to be thinking about it, but that's not the way we look at schools. That's not the way we look at all these other kind of things. And particularly as you talk about Black women and Black women in Detroit. So we had a guest earlier who said that, just a couple of days ago, Dr. Moore from the C.S. Mott Institute at Wayne State, where they look at preterm birth and some of the reasons that women are, and it was like, Detroit is absolutely the worst, right? It's like we have some of the highest, preterm birth and infant mortality rates in the country. And a lot of it has to do with Black women and not getting care. As a physician, as a Black woman, how do you see this process? What's been going on?
So you're right. Our numbers look bad. State of Michigan, Detroit, Wayne County specifically. Not just our county. You look at some other counties, Genesee, Flint County area. This has been a long time coming in terms of sort of the direction we're taking, where people are really, really, really legislatively, hospital-wise, administratively wise, looking at the numbers, because they are awful. That the our rates of maternal mortality are 2.5 to almost 4 times some other parts of the country, specifically Black women, Latina women as well. I think collectively, we've always known we've at a higher risk due to disparities. I mean, it's complex. It goes back to, it's disparity in healthcare just in general, which goes back decades and decades. But in this, current decade, the numbers are actually reflecting it, so that we have to address it. We have to address it from a policy standpoint. And it's across all demographics. It's social economic status does not deter you from the outcomes that we're seeing. Okay. So that's also, people commonly want to say, oh, the disparity is based on economic, educational disparity. It's not. There's some implicit bias going on in everything that we do, in terms of from the minute you start that healthcare process to that hospital stay to your postpartum care and visit. So it's very complex.
Yeah, and I mean, I'm glad that you mentioned that, the piece about the SES, because a lot of people are like, well, it's just because Black people are poor. It's like, no, it is across the board. Being a Black woman puts you at this higher incident of infant mortality and maternal mortality. And, we kind of got to this space because there have been so many discussions about, getting vaccinated and what people need to do, and kind of these fears about being vaccinated and what that's going to do to their ability to conceive or do those kind of things. And so Dr. Moore said that was, kind of, not to say that's not crazy talk, but that's not what the data would suggest. And that as we look into those kind of things, it's very clear that being vaccinated gives you a greater chance of being protected. But as an OB, what kind of advice and questions are you hearing from your patients as they're coming in and saying, should they get vaccinated and all those other kind of things?
So, like you said, very, very basic conversations generally start, well, in the GYN population, I've just talked to all patients from all reproductive ages. Common question, have you gotten vaccinated yet? And I've actually been fairly impressed in terms of the numbers. A lot of my older patients have definitely, I would say, vaccination rates in the older patient population, and we're talking 50 and upwards, probably is approaching 60, 70%. I find that the younger patient population is a little bit more hesitant, that 20 to 30-year-old age range is a little bit hesitant. In terms of the OB patients, the first question that, is asked is, how do we know the vaccine is safe in pregnancy? What would you recommend in terms of getting the vaccine? Timing of vaccination. When should I get the vaccine? I get texts from church members, family, friends, who often say, hey, my niece is pregnant. What do you think about getting the vaccination in pregnancy? So we know how this vaccine works, in that there is no DNA component to this vaccine that is going to impair. That's a common myth. You probably talked to Dr. Moore about that it's some type of infringement or impairment on your DNA process. It has nothing to do with that. The vaccine has no components that would deter someone from getting it during pregnancy. Our American College of OBGYN, the World Health Organization has stated that while we know we don't have the data yet, because it's going to take a while, the data will come fairly quickly because there was a large group of primarily physicians who were pregnant who got the vaccine. So they all enrolled in the vaccination trials on pregnant patients. So the data is going to start to come out rapidly, but we don't have the numbers yet. We know we don't have the numbers, so we cannot give a 5-year or 10-year data point on what happens as a result of the vaccine. But it's a mRNA vaccine. So there should not be any complications with getting the vaccine in pregnancy whatsoever.
So when one of your patients come in and say, "Hey, I'm pregnant. I'm thinking about, should I get vaccinated? Should I not?" What are you telling them?
So we talk about what are your fears and concerns about getting vaccinated. We talk about just feelings in general regarding vaccinations, because we know a lot of people traditionally don't get the flu vaccine. There are some other vaccinations that are recommended during pregnancy. Sometimes there's some vaccination hesitancy in our community, a little bit more than other communities. So we talk just in general about what is your impression, what have you heard about the vaccine, and try to go a little bit separating fact from fiction. I primarily try to address the fears and say, what are your fears? What are some of your concerns? We talk about the fact that, yes, we don't have the data to 100% say that this is safe, this is going to be safe for your unborn fetus. But I try to alleviate those fears by also offering the perspective of COVID's not over. We have people on labor and delivery every single day who have COVID. We still have moms going to the ICU as of 2 weeks ago with COVID. So the risk of COVID significantly outweigh some of the concerns that people are raising with respect to the vaccine.
And so for a pregnant woman who has COVID, how different is her pregnancy versus a pregnant woman without COVID?
So COVID, as we know, affects everyone very, very different. Pregnancy is already considered a condition where your body is immunocompromised. So your ability to fight off infections, viruses, the way you normally would is a little bit challenged because of your immune system as it relates to the pregnancy. So you're already challenged from that standpoint. In terms of pregnancy, the respiratory component, the moms also tend to decompensate very, very rapidly. So when there is respiratory decompensation, pneumonia, it's a very, very rapid decline. And at that time, you're often faced with making the decision to deliver the mom expeditiously. And that also, how far along is she in the pregnancy? Is the baby going to be viable? So the decision is not just based on the maternal outcome, but also the fetal outcome. And the decision is made, who at some point it becomes critical. Who are we trying to save? And we're always going to try to save the mom. You're going to try to save the mom. So the decision sometimes is critical in terms of when to time delivery. And it happens very, very quickly. I'm telling you, it happens quickly. Luckily, most moms are healthy, just like general population, and do fairly well with COVID. They may require oxygen. They may require hospitalization. Some moms are able to be managed at home. I've had some patients who are COVID positive who we've managed as an outpatient basis. But the concern is the decompensation. When it happens very, very rapidly. So you can have fetal compromise as well as the compromise of the mom as well.
So it adds another layer of complexity and scariness. It just makes everything move a lot faster.
Absolutely. and pregnancy is already a very challenging situation. A lot of people, consider pregnancy sort of like, oh, I'll see her after she's pregnant, other specialties, So now other specialties have to be involved. You have to have pulmonology on board. You have to have anesthesia on board. You have to have infectious disease on board. So it's like you said, it's a whole different layer to the playing field. So, COVID's not gone. I think we're looking at, the numbers, but every week I walk into the hospital, there's still a patient in those COVID rooms.
Yeah. And so as an OB who is delivering little people into the world, and people are constantly saying, hey, well, I'm concerned about, getting vaccinated, or I'm concerned about COVID. What kind of things are you telling folks as they are preparing to get pregnant, as they're like, hey, I'm thinking about this thing, even in vaccine timing, right? Is it, what do you say when someone's like, well, I haven't gotten vaccinated yet. I want to do it. When is the best time?
I think the best time is now.
That's what I like to hear.
Yeah, the best time is now, especially as you're planning. There is a study that's going to be published probably in the next couple of weeks from fertility study on just sort of like a 6 to 9 month trial on people who have gotten the vaccine, and is there a decrease in the fertility rates? Is there a decrease or a decline in the male semen analysis? And the study is looking very promising, which we knew it would be, but people want to see the data. So if you're planning a future pregnancy, why wait? Get the vaccination now so that you're protected. You optimize your chances of not getting the virus or one of the variants, which we still need to be concerned about as you approach that window when you're planning your conception time period. You don't have to worry about getting it during pregnancy if you've gotten it prenatally or prior to pregnancy, I should say.
Yeah. So I've talked to a number of doctors who have been saying that there is also increased risk of miscarriage for mothers who are COVID positive. Are you seeing any of that in your practice?
Oh, absolutely. I mean, absolutely. So, you talk anecdotally, you see other physicians. We talked about what we've seen in our hospital settings. I'm on some physician blogs, some OBGYN blogs. So you get to talk to people in different parts of the country, and everyone is emphatically saying, hey, are you guys seeing increased miscarriage rates? Also increased stillborn. We've also seen increase in stillborn rates. I mean, sadly to say, I walked into the hospital 2 weeks ago and there were 3 stillborns on our labor and delivery board. So that was pretty, is this a fluke, unusual, or, what's going on? Not all of the patients are necessarily COVID positive, but the data is going to be very, very interesting as it comes out, because we can't all be seeing the same patterns,
Right.
We can't all be seeing the same patterns. It's got to be attributable to something.
And so as we talk about kind of this as just one, I hate to pile on to Black women because I feel like that's the world that we're living in, but as we see COVID and this space as an additional stressor on Black women and their ability to carry a child to birth, or to, to full term and all those kind of things. What are other things that you're seeing in the space and that kind of contribute to that increased maternal, maternal death rate and lack of, inability to carry kids to term?
So that's a deep one. I think you're talking historically.
I mean, right now, like I think, as folks are talking, they are very concerned. A number of the folks that we talked to, and we tried to ask some questions ahead of time, and folks are saying, well, I've got so many concerns about. There's so many risk factors on getting pregnant already or being able to carry. They're like, they are concerned about adding, the vaccine or one more thing to the list of concerns.
And I don't think adding the vaccine is going to be, I think, it's apparent that I'm pro-vaccine, it's apparent. Just because we're already seeing the decline in the cases of the patients who are the sickest. We're seeing decline. We know the vaccine is effective. It's already since we've started administering the vaccine back in late December, we know that the numbers statistically support the efficacy of the vaccine. So when we talk about general maternal mortality, especially as it relates to Black women, so when I say historically, what's the historical component? I strongly believe a lot of that is implicit bias. I mean, it's really listening to your patients. It's hearing them, not just, seeing them, but also hearing. We've seen a lot of high profile cases, Serena Williams, a daughter of a daughter-in-law of a TV judge. There's a Black woman physician, MD, PhD from the CDC who died. So there's a lot of high profile cases centered around women who, have the skill set, the knowledge, and the voice to say something's wrong. And not to say that they were not all heard, I don't have the specifics of all those cases, but it goes back to people saying something's wrong and people kind of brushing you off as a Black woman, like, oh, right. The studies that look at our pain scores and how we get far less pain medication after C-section based on perceptions of pain, so it's that bias in which that you're treated in the hospital, by your doctor, and so we have a lot of other risk factors to start off with, right? We have higher risk, we have higher rates of hypertension disorders, obesity disorders. We have underlying transportation issues, economic issues, educational issues, understanding some of the instructions that are given or provided, or lack of having access to reliable healthcare. So those are all barriers that contribute. And then you get to the implicit bias piece where you are saying something's wrong and you're not being heard. You're not being heard. You're getting sent home from the ER saying, I'm having chest pain, something's wrong. And people saying, oh, that's just pregnancy. No, I'm having chest pain. I really feel bad. Oh, that's just pregnancy, until you've collapsed on the floor. I think that piece is big. I think now that it's become a priority, a precedent, not just for the state of Michigan, but nationally, I think people are seeing that we can't hide from the data. You can't hide from the numbers. When you have the data right there in front of you, there's no way to hide from it.
So, I mean, leaning in on that, and I'm glad you mentioned it, because it was one of those, I have a number of Black women who work for me, and they were all like, make sure you bring this up and ask about, particularly that piece on pain or not being responded to. As a physician, how should a patient talk to their physician and say, hey, this really is a thing? This is, is that okay, if your doctor isn't listening to you, switch doctors? Or is it talk to them this kind of way? Is there something that's missing?
And I think it's difficult because it's difficult on both sides. You're seeing 20 people a day. We know that pregnancy has a lot of a lot of symptoms. People have shortness of breath. People have lower, swelling in their legs. People have fatigue. People have contractions. But I think it's, what I like to say that I find too in my practice is I listen to what the patient's saying and I try to be objective, take out my subjectivity. Sometimes a patient has called me 10 times about the same problem, but something, I'll say, what's different about the symptoms you're experiencing now than before? Some of it's discernment of, knowing your patients and feeling comfortable, or something saying, what's really going on here. And not just discounting people based on, pregnancy related symptoms. We know that pregnancy related symptoms exist. You know that from being a dad, but really having some discernment. I think as a patient, you have to be your own advocate or have someone advocate for you. If you're not able to do it, if you don't have a a husband, partner, mom, doula, you got to have someone there to advocate on your behalf when you're not able to do it. Someone to say, no, something else is going on. I think if you have a good rapport with your physician, you should feel comfortable saying, hey, I think perhaps you're not listening or discounting some of the things that I say, and bringing it to their attention. And if you don't have a good rapport and you feel like I'm going up the wrong hill, then definitely changing physicians is also an option. You have to be confident with the care you're receiving. You have to feel comfortable that you're being provided the education that you need at whatever level of, your provider needs to meet you at the level you are. Your provider, if you have a education or some barrier to education or learning, it's our job, it's my responsibility to be able to provide that education at a level that you'll be able to understand. Not everybody speaks, the same language.
To that end, how did you pick your doctor? How do you go about it? I told you how we pick doctors, but that's also because we're a little crazy. But how do you pick doctor?
So my OBGYN was actually my current partner, is my current partner. My husband is also OBGYN, so he had been around a little bit longer than me, and I said, hey, who's good? Even though I was early in my career at that point. So you had some experience because you saw them firsthand with your patients. So I said, hey, who should I go to? Who are some of the physicians that you admire, that you feel like are empathetic, that are skilled, that are compassionate, and that you would want to have us go to for the care of our unborn child. And he gave me a couple names, and I didn't have as much research opportunity as you did, Adam, but
I know my wife, and my wife likes data, and she likes to be able to look at all the options. So I figured as a husband, I play a small role in having a child. I better do my part at the beginning.
Do your part, do the homework.
Yeah.
So I relied on him because I was newly back to the area and, didn't know all the players in the game, and was very, of course, happy with my decision. I did want someone that looked like me. That was important to me at that time. My son is 22, so 22 years ago, I felt that was important. Not to say that doctors who don't look like us aren't compassionate. They are. I know they are. I work with people every day who are compassionate, understanding, empathetic. But sometimes when you're concerned and you want to be able to have that face that looks like you, it's important. It's important, and that was important to me.
And that makes total sense. I think especially with all the disparities and with all these kind of things, I think it's something that is becoming increasingly common for people to be looking for it. I literally had this conversation as I was saying, Crystal is looking for a new, just doctor. And they're like, really? Is she a black woman? I want a black woman. I've been looking for, and it's just this kind of thing where it seems to be coming up. Is there a place where someone who does not have a close recommendation can go and look for or find one?
And I get this question probably 5-6 times a day. People who I've been seeing for years, and we're going through shifts in our country, and people are making some recognition, and people say, hey, by the way, do you have a list of primary care doctors, and who would you recommend? They want me to specifically go through the list and give them some personal recommendations, not just a generic list. Yeah. And I said, well, what's going on with your current relationship? And overwhelmingly, people are saying they just feel like they're not being heard. They're not being heard. And, my Dr. X is really nice. I've been with him or her for 5 years, but I just feel like I need someone who is a little bit more attentive to me, to what's going on with me. I mean, when I tell you, I get this question multiple times a day, and people are, if they have a good doctor, they're not going to leave a good doctor just for changing to a Black physician. They're going to stay with a good doctor. But when people are feeling like their care is a little bit compromised, or, you know, they're not getting their needs met, way more eager to move, you know.
Sounds like you have a second career as a doctor matchmaker if you want it.
Oh, is that what I'm supposed to be doing next?
Hey, I kid you not. I think there are a number of folks who would be interested in those recommendations. You can get your own,
Yes.
you know, like Michele's list, find your next doctor.
So yeah, but you know, it's a very common question. People just want, you know, they want to feel like their healthcare matters, not just to them, but to their provider. Like, your healthcare matters.
I always feel that when we come in and you aren't even giving me any care. So, you know.
You're so generous. And you know, I love you guys.
I kid you not. Like, I tell everybody, it's like, oh yeah, you're thinking about having a kid? You should go see Dr. Thomas. She's the best. And I'm always like, oh yes, her name was Michele Thomas. I was like, because I was gonna be like, hey, you want to go see Michele? I'm like, no, she's a doctor. You're gonna call. But it's just funny. You are such an important part of our life. And I think about, and the reason I think about it so stridently is because that is not everyone's case, you know, not the case with everyone. And I'm like, you have the most important job in my world, right? Like, in that couple minutes that everything is on the line, I have all of my faith and trust in you. Now, the first time I couldn't be in the room, the second time I was in the room, and that was cool. But it's like, there's nothing you can do about it. And there are not that many opportunities in the world.
Yes.
But you do that all day, every day. And it's a system where particularly Black women are seeing the data now that is saying, hey, this is super dangerous for you, right? Like, the likelihood that things are going to go bad is very low. And you still end up with all these people who are like, I don't know how to, one, advocate for myself, two, find the appropriate person to provide me with care, and three, not necessarily even sure if they got good care or bad care, or if it was them. And so in that last space, how do people know if they're getting the right thing? Because maybe they've never had a good, relationship.
That's a good question.
Like, so now I feel like you're doing relationship counseling. It's like, how do you know if you're in a good relationship? No.
And that's a good question. How do you know if you are getting good care? Because you may not have anything to compare it to. You know, I think you got to go with your gut. You've got to have a feeling that your questions are being answered. You know, you feel like your questions are being answered without feeling like you're burdening your healthcare provider. You know, you're not providing, we're providing education, service. You know, we do a lot of different skill sets, you know, and you have to do it in a timely fashion. You have to be able to answer a patient's questions, realizing you still have 3 other people in the room, but making her feel like she is special. She is the most important person to me at that moment. My attention is solely on the here and now. You know, I'm not distracted about the other people in the room. I'm trying to make you feel reassured. I want to direct you to appropriate resources. I can't provide all the resources. I can't provide information on birthing classes. We can talk about breastfeeding, and then I can direct you to the appropriate lactation consult. We can talk about prenatal classes, and I can give you the resources and say, hey, she does a really good job. We can talk about the role of what a doula does, and we can give you the resources for, that. So I think your patients need to feel like they're getting the comprehensive care that they deserve, and that their needs and education is being met, their expectations are being met. And also they should feel comfortable if they're in an uncomfortable setting saying, I'm not comfortable with this, or, I need more information. They should also be able to express their discomfort in a situation. I think that's really important. Patients, there's always been sort of that in our, historically, that hierarchical role. The doctor's here and you're there, and you kind of listen to the doctor like a parent. You don't question, or you don't have a discussion. I think it's important to be a team in terms of your healthcare. I tell you my recommendations, but I trust you as well to give me your input and say, no, I don't want to, I don't want to go that route. Or I want to avoid medications in labor. What are my options for avoiding, pain medications? I ask people, quite frankly, what's your plan for pain management? And, some people say, oh, I never thought about, they've not even thought about it, and you're assuming that people have already had this whole conversation in their head, and they have not.
So, is there anything else that people should know as they go through this pregnancy planning, from, hey, I think I want to have a kid, to, hey, I'm having a kid. Do I have the right doctor? I don't have a doctor. Is there anything you would just, that you should know these things?
So first thing I think is being the best health you can be. Okay. So we have to cut down or eliminate our tobacco, alcohol, marijuana, other substance use if you're planning pregnancy. Optimizing weight. We tell people even dropping 10% of your body weight in anticipation of pregnancy, if you're at a higher BMI, significantly cuts down on some of the subsequent risk of developing hypertension during pregnancy, gestational diabetes related issues, increased risk of C-section. So all of those things. So trying to optimize your health prior to pregnancy is really key. It's, I think we traditionally have not done that in the past, where we think about coming in for a visit saying, hey, we may be thinking about a baby within the next year. What do we need to do at this point? So trying to optimize your health is critical. If you're planning a pregnancy, we tell women to be on a multivitamin with folic acid. That's pretty key. Trying to be on that at least 3 months prior to conceiving. And the other thing that you can do is start doing your research. We have a wealth of information out there that we didn't used to have. So many women I see communicating on Facebook groups, blogs, and they're talking about not just in a negative experience impact, but positive experiences as well, in terms of what they liked about their healthcare provider, why they like their health provider. So they're sharing information from a positive standpoint, saying, I trusted my doctor emphatically. I had a C-section, but I trusted her. They're giving the full story, not just the one side of the story. I had this emergency C-section, but I knew if she told me I needed to have it, I needed to have it, So that's important. Start planning before you become pregnant. We don't do that a lot. And I think a lot of times if we start addressing some of those issues early, it kind of helps down the line. We're changing also the way we counsel people in terms of what signs and symptoms to look out for. We're starting to incorporate some different protocols and looking for early signs of disease processes that perhaps if we catch a little bit earlier, we have a chance to decrease those poor maternal and poor fetal outcomes. That's critical. I also do some work with the resident clinic at Providence. Right. And, we're trying to, based on the data we've seen, we're trying to get a maternal health educator in our clinic. So we're trying to do a lot of work. It's going to take a lot of time. It's going to take a lot of legislation. It's going to take a lot of money. The postpartum benefits are being extended to a year. Okay, so the state of Michigan is extending postpartum benefits, which is critical because most people who die after childbirth sometimes die within those first 12 weeks after delivery. So being able to go to your doctor and have extension of your benefits at that time is critical, because if you have a problem that still needs to be addressed, it can be addressed in a timely fashion. So I think all those things are really important.
Awesome. So I always ask people 2 questions as we kind of wrap up, which is, how are you staying physically active, and what are you doing for your own mental health? So you talked about the importance for folks who are planning to have kids, but just what are you doing to stay active?
So I'm a bike rider. We ride. on the weekends. We do pretty long rides, my husband and I. I have a stationary bike here in the house, so when I can't get outdoors and ride, I ride about 3 times a week. I eat fairly clean. I like to cook, so I do the majority of my own cooking because I find that COVID, we had to cook, we weren't going out. But I do better when I cook for myself. That's not to say that I don't enjoy dining out. I do enjoy dining out, but I can control what goes into my diet. So I eat pretty healthy. I try to maintain a fair amount of fruits, vegetables, greens, all those things in my diet. In terms of my mental health, I'm taking more time for myself, which has always been a challenge. I've learned that it's okay. The time that we spent during the pandemic, obviously I worked the whole entire time. So, but I felt a little bit of like, wow, I don't have to go to this meeting. I don't have to be there. So it's translating that I'm okay saying no, like, nope, can't do that, can't be there. And, if that's time to spend, doing some reading, catching up on some journaling, then that's important to me.
Awesome. Well, I really appreciate you taking time to be
no
with
problem.
us. This has been another episode of the We Can Do Better podcast with my favorite doctor, Dr. Michele Thomas, who has delivered both of my little people. And it's just amazing. So thank you for taking the time.
All right. Thank you for having me, Adam. It's a pleasure. I hope I'll join you again. I'll invite Dr. Hero. I know you guys wanted to get us both. We'll come back and chat with you hopefully soon.
Looking forward to it.
Okay. Thank you.